Hello, everybody. Welcome to our second episode of Curriculum Corner, the podcast where we dive deep into the essentials of medical training and beyond. I'm your host, Arthur Ollendorf, and today we are having an exciting episode lined up for you. We know that teaching and learning in clinical settings can be challenging, but it's also one of the most rewarding parts of our journey. Whether you're a seasoned resident or just starting out, mastering the art of clinical teaching is a constant work in progress. That's why today we're going to talk about the 5 micro skills of clinical teaching. These micro skills are simple, yet incredibly effective techniques that can enhance your teaching abilities and make learning more impactful for your peers. Joining us for this episode are Dr. Kim Simcox and Dr. John Epling. Dr. Simcox is an associate professor of OBGYN and an addiction medicine specialist. She brings her experiences as a previous clerkship director and a current fellowship program director. Dr. Epling is a professor and vice chair of family and community medicine at Curlian Clinic and VTCSOM. He's been teaching learners at all levels about family medicine, evidence-based medicine, public health, and clinical prevention for nearly 30 years. He has a master's degree in instructional design, development and evaluation, and regularly conducts and reviews educational research. First, I want to welcome both of you. It's great to have you here with us and really about something that's a cornerstone of the clinical environment.
Thanks for having us. How could we say no to you, Arthur?
Thank you.
So let's get started. So the 5 micro skills of clinical teaching are comprised of 5 consecutive steps based on adult learning principles. This approach is known as the 1-minute preceptor model. It's become a foundational teaching technique that supports teaching when time is limited. I know that you both have a great deal of expertise in deploying this technique. So we'll start with some general questions. I'll start with Dr. Epling. Can you please explain the 5 micro skills of clinical teaching are and why they are important?
Sure, thanks. The concept about these micro skills and this kind of new way of teaching, clinical teaching, is mostly that it's an efficient way to promote learning in a busy clinical environment. And the words promote learning are really important here. This is a very learner-centered approach. I think of it as similar to behavioral motivational interviewing, where we're trying to get our patients to change behaviors by assessing where they're at and trying to move them to the next level closer to their behavioral goal. Similarly, we're taking students, assessing where they're at cognitively or skill development wise, and trying to move them just to the next step. So it relieves a little bit of pressure on teachers. It makes the learning very learner centered, and is a nice and efficient way to promote learning in that clinical environment. So the micro skills themselves are pretty straightforward, and they reinforce these concepts. The first is to get a commitment, and this is most often a behavior that demonstrates what they know. So it could be coming up with a diagnosis, a working diagnosis, or final diagnosis, coming up with a management plan, performing a skill, a surgical skill, or a physical exam skill, something like that. Then you want to probe for evidence. That's the second step. So you find out what's behind their thinking. Key question here, help me understand how you came to that diagnosis. Help me understand why you chose a shave biopsy versus an excisional biopsy. You're getting at what they actually know that supported that cognitive behavior, if you will. And then teach general rules. And that's the third step. This is not a 5-minute lecture on the most you know about that particular concept. Think about it a little bit more in the metacognitive way, in terms of thinking about how they're thinking. How do you approach these patients? How do you generally categorize that knowledge? How do you generally think through these types of problems? That's the general rule type of thing. You want to, the fourth and fifth items here are the micro skills are about feedback. You want to reinforce what was done well, pick out the good stuff that they did that helped them arrive to that initial commitment, and then correct mistakes. And this is to prevent mislearning. We don't want that to happen. Now, you don't have to go through absolutely everything they did wrong. You want to really focus this on the general rules concept, how you're thinking, and the way they approach the problem. Those are the mistakes you want to be correcting. And of course, anything that's critical to patient care. And that'll depend a lot on the level of learner you're talking about.
Yeah, that sounds like an amazing approach. I mean, how does this 1-minute preceptor differ from traditional clinical teaching?
Mostly, it's convincing teachers that it's not about them. It's not about their performance. It's not about entertainment or the breadth of their knowledge. It's about assessing the individual learners and figuring out what they need to take them to the next step. So it's about engaging the learners. It's about assessing where they are. and providing them the feedback to improve, creating the conditions for them to improve their cognition and their skills.
So Dr. Simcox, you've been able to use this both in the clinical setting with medical students, residents and fellows, a whole range of learner types that we have in our institution. How do you use these, and what are the barriers that you found for your use or when other people are using it in the clinical environment?
So I love the Microskills. They provide an opportunity for formative, real-time, super efficient feedback. I mean, but there are some challenges that we all have to navigate. You know, we're trying to teach with significant time constraints. We have fast-paced clinics. We're managing inbox calls, results in between the patients, and learners might take a little bit more time collecting histories, which can put us a bit behind. And there are different clinical settings and learner levels that may have different approaches. They have all different attributes. They may have differing levels of desire, readiness for autonomy, and some may not readily engage in that reflective practice yet. So, and finally, striking the right balance between positive reinforcement and correction can be a little challenging, but we'll talk about how to navigate these things today.
How about we talk about them right now? I mean, that'd be a great opportunity as you're thinking about it, because I think we all struggle with that, right? We want to be
Right.
positive in our guidance with our learners, but at the same time, we do want to correct mistakes in real time so they don't propagate. So how do you find that balance?
So I find that that positive reinforcement, I'm just a generally positive person, you know this, it can be a very powerful tool for shaping behavior. And when learners see that their certain actions or behaviors are recognized and actually valued, they're more likely to repeat those behaviors and maintain them in their practice. Research does show in medical education that when learners receive affirmation for what they did well, they're more likely to stay motivated and engaged in their learning process. And it also helps build that trust and rapport between the educator and the learner. So when my learners feel appreciated and acknowledged, I think it strengthens our relationship, and it makes it more easy for them to it makes them easier for them to receive and act on constructive feedback.
It makes it really interesting having both of you here, Dr. Epling and Dr. Simcox, as a family physician, as an OBGYN. It sort of reinforces that we teach in very different learning environments. I'm an obstetrician also. Teaching in labor and delivery is a unique place to teach. Teaching in a labor and delivery operating room where you have an awake patient and a family member watching you is also a unique situation. So, we all have these experiences. How do you adapt this to the different learning environment you're in? And maybe Dr. Simcox, you can start with things that are more surgical or procedural in nature.
Certainly. So, when we start with getting a commitment, that can be something like ask before the procedure, asking that learner to articulate those planned steps. What do you plan to do? Which techniques do you plan to do? Where do you plan to put the incision sites? What are the key landmarks we need to pay attention to? What are some expected challenges for this surgery? Like she might have 17 hernia repairs or something. So, and then we probe for that supportive evidence. We want to ask the learner why they're choosing that particular technique or instrument for a specific task. And when we teach the general rules, we can, also do this after the procedure too. If you're operating, you don't have time to do a lot of clinical pearls, you can provide that guidance on general principles like maintaining hemostasis, avoiding mistakes in suturing, or managing those intraoperative complications. And then after, you want to reinforce what was done well. And I actually do this after and during the procedure to make them more confident. I praise the learner for their precise technique, their effective retraction during intraoperative bleeding management. And then when we correct the mistakes, and I do prefer, instead of correct mistakes, opportunities for improvement is what I like to say. I tend to focus on a behavior or an action, not a characteristic. If that learner makes a mistake, like an incorrect tissue handling, you'll want to discuss that immediately, usually. But then later, you can give examples of what they could do to practice and improve, like videos, simulations, or watching a particular surgeon who excels at that technique in a later surgical time.
Yeah, and I always like the correct mistakes part, and I like the opportunities for improvement. And there's sometimes the resident or fellow doesn't make a mistake, and I use that as an opportunity to say, what could you do better to get to that next level? It's like, this would be, you're doing the surgical procedure. If you held the instrument this way and approach it this way, would that be something that would work well for you? So trying to like push them to, become even better, even when things went relatively well. So
Totally. That's a good one.
yeah. And Dr. Epling, so in the outpatient setting, how do you tend to employ this technique?
Well, I loved listening how Dr. Simcox talked about how she brought this into very details of surgical education. And the value of this technique is that it's portable. You don't have to have a PowerPoint slide and a lecture notes written for you. You can take this into the room with a patient. You can take this into the procedure room. You can do it in the clinical precepting office. You can use this technique in a bunch of different ways. And I think my favorite one about how to make this most relevant to both the patient and the student and the learner is to do this in front of the patient. So one of the examples I give was for physical diagnosis. If I'm teaching otoscopy and trying to make sure the learner is doing good quality otoscopy, I'll often involve the patient. So we'll go through, I'll have the learner perform. We'll talk about general rules about how I hold the otoscope and how I position the patient and move the ears and all that sort of stuff. And then I ask the patient to participate in some of the feedback, and they feel like they're part of it. And I set it up okay so that everybody knows what's coming. But ask the patient to say, hey, did that hurt when he did that, or did that feel okay? And how did that feel compared to how he did it before? And I think it's really effective to engage the patient in this. They learn something. They learn something about what I'm doing when I'm looking in their ears. The learner is very invested in this because they're in front of a patient. It's got their attention very clearly. So I think the opportunity to do this in multiple different settings really reinforces the utility of this tool.
Yeah, so we've been talking a little bit about this, and before we start talking about how the residents and fellows can use this in their teaching, can you give us an example of running through a case like this, how you would do it? Do you have like a best of in your brain of how you use this specifically in a patient care setting?
I can take that, and then Dr. Simcox can weigh in. So I had a student recently where he presented a case of a new paresthesia in the left arm, and this was in a patient that also had diabetic neuropathy and was on gabapentin, for instance. So I asked this student what they thought was the working diagnosis, and it was very clear that things were jumbled. There was peripheral neuropathy, and there was also this paresthesia, and I didn't get a clear sense of that they were thinking through the problem clearly. So we asked them to break down what they found on an exam to help kind of differentiate it, and it was clear again that we were in a little bit muddy territory. And this, I think, is a result of the memorization that we have to do in order to pass the gateway exams in medical school. So it's to be expected a little bit. So I think the general rules that I employed here were to figure out how do you look at different nerve related complaints, and how do you sort them into polyneuropathy and mononeuropathy and peripheral neuropathy. And we didn't go into the details about each individual diagnosis and what happened. It was more of this metacognition. How do you break that down? How do you approach that? How do you look at what I call syndromic diagnosis, the different syndromes that themselves have different differential diagnoses? So we talked about that a little bit. I praised them for figuring out that the patient had also had diabetic neuropathy and was on a neuropathy related medication, because that's important to how you might manage that. And then we talked about correcting the working diagnosis based on one of these syndromes. And that was a sort of a brief way that I ran through all the 5 steps in a relatively quick format. I didn't spend a lot of time on the detail. I talked to the student about maybe you can go read about each of these syndromes and come up with a couple of differentials that are appropriate to each of these syndromes, and you can go learn yourself. We know that our learners these days are very self-sufficient, can learn things if we give them the opportunity and structure it for them a little bit.
Excellent. As we start getting to more like the practical aspects of this, sort of a 2-part question for Dr. Simcox. One is, how do you utilize the 5-minute preceptor when you're in a busy clinical setting? And then kind of moving forward, what kind of advice would you give residents and fellows about how they would do that in their very busy settings, and how they can integrate these skills to use in a consistent way?
Sure. I like to, set up expectations at the start of the clinic day. I think students really like that. They like to feel prepared, knowing what's coming. I usually assign, 2 to 3 patients to the student per clinic session. And then I let them know that I expect them to formulate a diagnosis and treatment plan so that we can kind of dive straight into that getting a commitment. And then I tell them that if they're in the room taking a history and they might be taking a longer amount of time, you know, I'm going to say, hey, after, you know, 5 minutes, I may come into the room for you. And that way they can focus on that patient interview, honing those skills to make an effective interview, and you know, kind of guiding the patient questions, and that kind of allows. And you know, I tell them I do that because I want to allow time for me to be able to teach them. So I give them that time limit, and then say, okay, this will allow me to focus on you and your mic and teaching you some clinical pearls. You know, and with the residents, you know, we tend to have some complex patients with multiple issues in resident clinics, and you know, I'd recommend having them focus on the micro skills for like one issue per patient. For example, you know, managing BV in a patient, or bacterial vaginosis in a patient that's there for an annual exam. And oh, by the way, they have like 7 million other complaints. So I typically ask something like, what do you think is the source of her vaginal odor and discharge? And I'm very sorry for you non-OB people if you're eating during this podcast, but we we like to aim for one general rule or one pearl per patient encounter or complaint. So for example, for bacterial vaginosis, we may focus on AMCEL's criteria for BV diagnosis and not address the 40 other complaints, right? And then for some quick math for the residents, I know they like math. And, you know, when you just pick 2 to 3 patients a session for the microskill teaching, it only adds 10 to 15 minutes onto your day. And you can make up for this on the back end by having the student do some notes and help you catch up a bit. The students, like, they very much appreciate the opportunity to write notes, to reflect it, like that really kind of reflects and further reinforcing what they learned from your teaching. And then if you probed for that evidence and you could tell they're bluffing and they really didn't know how to support their primary diagnosis, that time will allow them, you know, that will allow them the opportunity to, you know, do some research while you're in seeing other patients and providing that supportive evidence while you're seeing the other ones. And if you're seeing an interesting patient while the student's documenting, or that patient doesn't allow a learner, which tends to happen sometimes in obstetrics for sensitive exams, you can also give a brief synopsis of that patient. So I might present the patient and what I saw, what the patient reported to the student, and then do a rapid 5-minute microskill teaching based on what I told the learner. And that's an efficient manner, that's an efficient way to teach them that skill if they weren't allowed to actively participate in that interesting patient's care. And then, you know, I typically, and to echo what Dr. Eppeling said, I do sometimes teach during the patient encounter. You don't always have to go in a specific micro skill order. So, and I think that patients really like actively participating in medical education. So I might ask for, you know, teach a pearl in front of the patient. And then afterwards, after when we're out of the room, then I'll probe for supporting evidence and provide opportunities for improvement outside of the room, so it doesn't put too much pressure on the student in front of the patient.
You know, Dr. Simcox, I love the flexibility that you sort of demonstrate here. And we, you know, in clinical care, it's become a little bit, as we're all busy, it can feel like drudgery. Oh, I have another student to teach or something like that. But here we're talking about, if you let go of these presumptions about how much we have to do, we have to cover all of medicine for this patient and for the student and teach them the whole thing. If we let go of some of those expectations that we put on ourselves, we have this enormous creativity. You can do things like just what you talked about, Dr. Simcox, of flexing the learning to different situations and reordering the learning a little bit. And it's a really a good chance to engage yourself in teaching as well as the learner in learning. I think the letting go is the most common thing. I think getting over yourself, that you're not there to entertain and to be didactic. You're there to help the learner achieve the next step in their learning. And I think those are really important things.
Right.
So it sounds like you both have used this very effectively, and I think, you know, stories are always very helpful. So, you know, could each of you share a story where, you know, using this process was particularly helpful, or like, you know, the aha moment where this is a really good thing to use? I think, you know, the residents and fellows would love to hear that from people who enjoy their educational mission, and can share that.
Sure. I think I like to set up those expectations early. So sometimes, I've even taken the approach of sharing that 1 minute preceptor model before the day starts. This is what I'm going to do. And it may be in this order, may not be. And that way they know what they're coming into. They're prepared to dive straight into getting that commitment, right? So they're already thinking for next steps. We're trying to prepare our learners to think to the next step, right? So if they know that I'm going to ask that, they're going to start kind of ticking through those differentials when we're talking to the patient. And the students say that they like to know what teaching model that I may be using because it helps them. It sets, it relieves kind of their anxiety. Students don't like a lot of surprises, especially early on. So, the other thing that I have gotten some positive feedback on myself is when I will very intentionally say, I'm giving you feedback. I basically say, now I'm going to give you tips on things to keep working on. I want you to get the most out of your time with me and come home with some pearls. And then I balance that with what they did well and behaviors that they should continue in their future practice.
Those are fantastic ideas. I think the example I gave about the student with the neuropathy thing, I asked him at the end of the session, because I generally do try to ask for feedback about how I can be a better preceptor. I think that keeps me engaged and helps me just focus on the teaching task at hand, which is important to me. And he said, after the first session we did with this, he said, boy, I realized after that first patient that I really had to be on my game. I really had to, and it's sort of a shame that we don't come in with that expectation. On the other hand, it's really nice that he realized that he was being asked to explain himself and to go through the teaching, and did really appreciate the attention we had to his cognitive development, his learning in that respect. And so that's kind of nice to see that you get some good feedback about students in a relatively easy manner. You get good feedback from students that you're actively teaching them and giving them feedback and these other things that Dr. Simcox was talking about. I think her idea of talking to the student beforehand and saying, we're going to be doing this today, is a way to get your own commitment to this process. You can post a sticky with the 5 microskills to keep yourself honest, remind you. I think there are all sorts of ways that you can make this a more valuable experience, and also kind of let the learner know what you're doing and decrease the tension around the encounter.
Ooh, I like the sticky note. That's a really good idea because then it will make me remember to do it and commit myself. And I love that. I'm going to use that.
Yeah, no, I think these are really helpful. These are like these practical things, right? So, if I was listening to this podcast, like, wow, that sounds really great. What are some practical things I can do right now? The reminder, the sticky notes, the framing. This is feedback that we're going to give you. Explaining what what the 1 minute preceptor is, and saying, hey, this is the process, so they understand it. It's a shared mental model for the QI people. So for our residents and fellows who, are all excited about this now, like, I can't wait to use it now. Are there some simple resources, that are out there that they can look at and use? And obviously we'll share those with the content of this podcast, but anything you can share that worked really well for you when you first started using this method, or something they can refer to as they try to get better?
Oh yeah. Oh, I love the Lego surgery 1 minute preceptor. And I think Arthur, you introduced me to that video. It is, pretty for people with short attention spans like myself. That really helped. It adds some humor, and they have like Lego people that are doing the talking, and everybody likes Legos. So I thought that stuck with me for some reason, but that just tells you my level of maturity. So
I like Legos too. I fully support that idea. I think the involving the student, I think, in your journey a little bit is helpful. Again, it de-emphasizes the importance of you teaching, and it's more about them learning. So you say, hey, I'm trying this new thing that I want to be a more effective teacher. At the end, I want you to tell me how you think it went, because I'm trying to improve this too. It's granted that you already know your stuff. You're already at a level where you can teach them. So that's less important as the quality of how am I helping you learn. And I think engaging the learner in giving you feedback is important. Secondly, when you're ready for it, this is not for everybody right out of the gate, is get either colleagues or maybe an attending to listen to you do this and give you feedback from that. I think that's, you got to make sure that you're feeling safe about that, and maybe want to get a little practice under your belt before you do that. But I think that can be a fantastic and culture building way to improve education with your colleagues and with your attendings.
Mhm.
Yes, Dr. Simcox, Dr. Appling, thank you so much for sharing your experiences and sharing your wisdom with us. And as we sort of kind of wrap things up, a couple things for the podcast listeners to think about. And when you really think about the 5 micro skills of clinical teaching, remember the 5 parts of this model. One is to get a commitment and encourage the learner to make a decision. The second one is probe for supporting evidence. Ask them to explain the reasoning. Are they getting the right answer for the right reason? Teach general rules, give them the bigger picture, things that they can use not with this patient, but for any other patient that had a similar presentation. Reinforce what was done well, highlight those things, and correct mistakes, also known as offer constructive feedback. You can call it anything you want. These are things that, once again, you do them more repetitively, and they become part of your everyday. It becomes sort of natural, and it's not really work. It's just bringing that joy into the teaching, and your students, your junior residents, whomever you may be teaching, will truly value from it. So integrating these skills in your daily practice can truly transform the way you teach. It's about making the most of every clinical encounter, and really finding that value in teaching like we talked about throughout the podcast. Until next time, keep learning, keep teaching, and most importantly, keep caring. This is Arthur Ollendorf signing off. Take care, everybody.